Hi, everybody. My name is Erica Voss. I work at Janssen Research and Development, but I'm also a PhD student at Erasmus MC. And today I'm going to be talking about a recent publication titled Contextualizing Adverse Events of Special Interest to Characterize the Baseline Incidence Rates in 24 million patients with COVID-19 across 26 databases. Okay, let's see if I can actually turn the slides. Okay, so at the beginning of the pandemic, before any vaccines hit the market, regulatory bodies were discussing, hey, once these vaccines come out, there are going to be adverse events that we need to study. And so here are a list of adverse events that we think we should pay special attention to once the vaccines become available. Things like acute myocardial infarction, anaphylaxis, and appendicitis. And so when this list came out, the Odyssey community thought, hey, there's work that we can do now. We can take these conditions of interest and actually do some produce incidence rates in a background population so that we can understand how often do these things actually happen in a general population. And so community got together and produced a paper that did just that, looking at the adverse events in a pre-pandemic population so that we could understand what the background rate is. And I may refer to this paper as the Jintong paper throughout this presentation. Now, this study that I'm talking about today is a little bit different in that we kind of did the same idea, but instead of looking at the pre-pandemic population, we looked at the COVID-19 population. We wanted to understand how often do these adverse events happen after COVID-19. And we thought what was interesting here is as the vaccines were going to start hitting the market, and we were concerned about these adverse events for the vaccine, it would also be good to understand how often do these adverse events happen after COVID? And you could start to build a benefit risk profile. If an adverse event can happen after the vaccine, but it also happens after COVID, you have to think about that in terms of should I get the vaccine or not get the vaccine? So we put together a protocol which was publicly available, and the community provided feedback on the protocol. And what that protocol talked about was, okay, who are we going to study? So up until us developing this work, the Odyssey community had done a lot of work trying to think about how do we define COVID-19? And there was already a really great phenotype that looked for COVID-19 individuals that either had a positive test or a diagnosis. And this study was able to just leverage that work that was already performed. Additionally, we also brought in the pre-pandemic population because we were really hopeful that we were going to bring in additional data sources that the previous work by Xintong did not include. So we included that target population as well. We included the outcome cohorts, all those AESIs that we saw on a previous screen. They were included within this study. We also stratified by age and sex, and Xintong's work found that that was important, and I'll highlight that later in the talk. We looked at a bunch of time at risks, but we focused in on the 90 days, and we produced things like counts, incidence rates, and incidence proportions of the outcomes. We used tools like Atlas to produce our definitions, and so that pre-pandemic population exists as an Atlas cohort. You can go out and view it today, and it's basically looking for individuals who existed in the database at certain points of time. Very similarly, we use Atlas to produce our COVID-19 population. And again, this definition was built within the community as we learned about how COVID-19 actually persisted within our data sets. And this study just got to leverage all of that work. So as we started putting our study together, a thrombocytopenia also became an important adverse event, a special interest. And again, the Odyssey community had done a lot of work to understand this condition. And so we were able to leverage that work and also include that as an outcome. This study was able to run over 26 different databases and was across 11 different countries. I know for me, this was the first time I had run a study in Estonia, in Serbia, and Turkey, and so I thought that was pretty neat. Now, when you have 26 databases, it's kind of annoying to go through and list them out all individually. So I'm able to group them up and give you a gestalt of what's going on. So a bunch of our databases were administrative claims databases, things that are usually tied to insurance. So when I think of administrative claims, I often think of the IBM Market Scan databases that are pretty popular in the US. We also had general practitioner data. So this I typically think of as outpatient-centric data. And so when I think of general practitioner data, I think of a CPRD. We also had electronic health records. And when I think of these types of databases, they're usually some combination of inpatient, outpatient, or maybe just outpatient. And so when I think of electronic health records, I think of Columbia University Irving Medical Center. And finally, we had one really unique data set, and that was the UK Biobank, which combined electronic health records with a registry. Now, if we assume all our databases are fairly mutually exclusive, we can total up our population and see how many COVID individuals do we have and how big was our pre-pandemic population. And we had about 24 million COVID-19 subjects, and we had almost 493 million in our pre-pandemic population. So very large groups of people to look at. What I'm showing on the screen is just one of the analysis that we produced. And so what we're looking at is the pooled estimated age and sex stratified incidence rates per 100,000 person years. And we're looking at that in the pre-pandemic population. What we see down the side here are all the different AESIs stratified by sex. And then across the top, we see the age distributions. And what we've done here is we have applied a classification system to these incidence rates. And that classification goes from being very rare, rare, uncommon, common to very common. And you can see by the colors what the incidence rates, how they were persisting in this pre-pandemic population. So, for example, across these 16 adverse events of special interest, we saw in general, these items were either very rare to rare. We do also see what Xintong saw is that we do see age sex stratification differences. So, for example, in acute myocardial infarction, we can see that the incidence rate changes as the patients get older, and in some cases based on their sex. So remember the colors here. Now we're going to go to the COVID-19 population. And there's a difference in colors. So we have now moved with our COVID-19 population from very rare to rare into uncommon and common. And what this suggests to us is that these adverse events, there's something going on here post COVID-19 versus just a general population. In order to be able to kind of more succinctly tell that story, we did kind of compare the incidence rate from that COVID-19 population versus that pre-pandemic population and did a meta-analysis across all the different databases. And what this allows us to show is that when we compare those two cohorts, more often these adverse events of special interest are happening more for the COVID-19 population versus the pre-pandemic population. So, for example, pulmonary embolism looks to be happening about 12 times more often in the COVID population when we compare to the pre-pandemic population in the 90 days after index. So there definitely seems to be going something on with these adverse events in COVID. So to our knowledge, this is the largest study to date on descriptive epidemiology of ASIs among COVID-19 population. It is also the largest Odyssey study, and I'm going to hang on to that as long as I can, but I don't think it will be for long. I did not talk today in this presentation, but in the paper we talk about there was considerable heterogeneity in the incidence rates among COVID-19 cohorts by geographic area and database. The paper goes into more detail on that. I did highlight the considerable variability with age and some sex groups in emphasizing that need for stratification. We saw that in those colored charts. Thrombotic events such as AMI, stroke, CVT, pulmonary embolism were more frequent compared to other ASIs and were uncommon to common in older COVID-19 subjects. And then finally, in most databases, the risk of these thrombotic events was higher among COVID-19 subjects when compared to the pre-pandemic population. So that was just a quick review of the work, but I wanted to thank all my co-authors because either they provided data or they provided analytics support or provided help in just contextualizing this. It was definitely a group effort. So thank you very much.